Order is a little bit past 6:30. We have two people with us virtually. That's Angie, Nickel, Connie, and Todd. So they're on. I think you can see them there. Thank you. And then we also have some guests. So if you'd like to tell us your name and why you're here, we would appreciate that.
My name's Gina Alcorn. I'm a nurse at Kettering Health main campus, and I'm here as part of my clinical ladder project.
Yeah.
I'm Katie Spencer. I'm a student at the University of Cincinnati. I'm a grad student there, and I'm here for my class.
Okay, well, welcome.
Thank you.
I'm Clint Connor. I'm here to discuss some of the rate hikes on the sewage treatment.
Okay. Well, welcome. Thank you.
Thank you.
I need a motion and a second to adopt the consent agenda and also for the minutes of the last meeting.
Got one.
You're right.
You said it right.
Just kidding. Great capture.
Yeah, okay. Thank you.
Ms. Jane, sorry, you want to do the amended agenda?
Oh, yes.
Yes.
You have an amended agenda. And what you need to do is add on number 5 for committee reports, add nomination. Committee,
And would you like to move 6A?
yeah.
For the second reading?
And 6A for the second reading, we'd like to move that up so that we can take care of that and Clint doesn't have to sit through the meeting.
Thank you.
So
moved.
Okay. Second. Okay. All in favor? Oh, any discussion? All in favor, say aye. Opposed? Okay, we'll go ahead and move number 6 up, the second reading and hearing of the proposed environmental health fees for 2026. And those were given to us at the last meeting. And Shadrick went over all of that for us. Does anybody have any questions or do you want to add anything to that?
No, there's nothing to add. Yeah.
Questions on that? Well, I guess we will allow them, Clint to go ahead and speak.
Perfect. Like I said, my name's Clint Connor. Not
You
only
have 5 minutes.
Okay, thank you.
you.
I'm not only a Greene County resident, I'm also install sewage treatment systems. My concern with the raising of these fees isn't the fact of paying them. I don't mind paying for excellence. But where we are and what we are getting did not fall in that excellence category. Our site reviews, we're being told from installer side that they take up to 30 days for them to get approved. I called the surrounding counties. They are giving them back in 7 days or less. Clinton County is the only county that is longer than 7 days. But they do internal designs. So that's understandable. The last design I got back, it took 20 days from the time I submitted it till it was returned. When you are trying to perform business, 20 days, 30 days is what we were told. 20 days and 30 days to continue running business is exorbitant, especially when you are raising your fees higher than any other surrounding county. Your fee total will be $1,170, and the closest county to those fees that are in our area is $874. So like I said, I don't mind paying for excellence, but I would expect to get excellence in return. And 30 days on site reviews, that's not excellent. That's all I've got.
Thank you so much for your comments, Mr. Connor, and just be assured that the board members do listen to all of these comments. The adoption fee doesn't occur for another 30 days, so at the next Board of Health meeting, but we do really appreciate hearing from you on your concerns.
Thank you.
Thank you.
And I think we have another guest. Would you like to?
Hello, sorry, my name is Amber Kruger. I'm from Kettering as well, doing clinical ladder.
Oh, welcome.
Thank you.
Okay, we'll move on to our presentation. And it's arsenic and raw water, by Chadwick.
Right. It's all right if I sit. Can everyone hear me if I speak up? Yep, okay. So this presentation is one I gave to our professional organization almost exactly a year ago, this week, as a matter of fact, the Ohio Environmental Health Association. Some years ago, next one, who's Olivia? Again, I'm sorry. See, we'll go through it this way. Arsenic is a heavy metal that has been known to humans for many years. It was isolated by an Arab fellow, Jabir ibn Hayyan, in about 1815 AD. Its name comes from a Greek word meaning virile, and it's known as one of the worst of the toxic heavy metals that we have to deal with nowadays. What's interesting, though, is that while we certainly can associate arsenic with industrial pollution, the arsenic we deal with here locally actually is naturally occurring. Next slide, please. We do use it in all sorts of things. We used it in pesticides up to 2013. We had it as livestock additive, feed additive at one time. It's been used as medicine and still used for certain unusual parasitic diseases like trypanosomiasis. We use it in electronics, and we've used it in weapons, unfortunately. Next. This is what we'll call a heat map of naturally occurring arsenic concentrations in the United States. And as you can see, practically the whole of Ohio is there in the red zone. A lot of our arsenic comes from minerals that were drugged down by the glaciers from Canada. So we're dealing with Canadian rocks that have high arsenic levels. To put that in perspective, though, why it's an issue for us is that about 1 billion gallons of groundwater are used in Ohio every single day. And that's why it's such an issue. 40% of Ohio depends on groundwater, either through private wells or through public wells, in order to supply their needs. Next slide. All about bottled water. Next slide. Is it better just to have that? Well, it turns out I actually cut a video from here that was about 15 minutes long. A study recently found that some popular drinking water, bottled water, had over the limit arsenic levels in it because they weren't testing for it. And so it was making it through the filtration process, but that process wouldn't do anything for elemental arsenic. The US EPA set a maximum contaminant level of 15 with the goal of 0. It used to be 50 25 years ago. So we're making progress in our standards. Around here, we get nervous at 10 micrograms per liter. We're talking about parts per billion at this level. Next. All right. So here are some of the problems that come from exposure to arsenic. In a minute, I'll tie this into Greene County. Next. It can cause muscle cramps, a very specific clinical manifestation called Mees lines, which gives you those stripy bits on your fingernails. It can cause upset stomach and diarrhea, something called hyperkeratosis, which is kind of a scaly skin disease on the palms and on the feet. And it can cause nervous problems with hands, numbness and tingling. Next. It's also been linked I put these two up here to cancer types, these two, lung and bladder, but in fact, arsenic could cause cancer in a great many bodily systems. So those are the two prominent ones. Next. Now, let me tell the story. Back in 2018, I got a phone call from a person here in Greene County who said their doctor tested them for arsenic, I believe it was a hair test. And she said, I would like to have my well water tested for arsenic. So as a sanitarian, I had never heard of this, and I thought it was about the craziest thing I ever heard. So I did a little investigating and found out that we could test for arsenic. It wasn't particularly expensive. We agreed to do it. When we got her results back after about 2 weeks, we found that the levels in her private well were 10 times the limit, 10 times what they were supposed to be. You can imagine living, it's one thing to ingest water over the limit once or twice, but if that's the water that you drink every day, that you're brushing your teeth with, that you're exposed to, obviously that's going to cause problems. And sure enough, there was a direct clinical connection to that person's situation. We tested homes, well, we tried to get neighbors to submit to arsenic tests too, to see if the issue was how localized the problem was. And sure enough, two of her neighbors did agree to it. And we found levels that were also high, not as high as hers, but also pretty significant. So that got us thinking, if we're seeing this here, and I think it was in Beaver Creek Township, did I say that? I got to be careful of my HIPAA here, but we saw high arsenic results in a semi-urban area. What's happening everywhere else, right? Next slide. Let's see where we are. For sanitarians, it caused us to think, we test regularly. Every time there's a new well, we test for bacteria, 2 different kinds of bacteria. We test by law for nitrates. Nitrates affect especially newborns and young children. But are we overlooking something that's having a very real impact on citizens' health just because we never heard of it? And the truth was, yes, that's what has happened. Unfortunately, my field has moved on from some of the basics like arsenic or heavy metal contamination to worry about things like PFAS, right? Everybody's familiar with microplastics. They are a legitimate concern, but we're far away from seeing the clinical impact from PFAS that arsenic is already having. Next. So Greene County, my team came up with a plan. How are we going to see how big of a problem this is for us? So what we decided to do is a subtle tactic, right? We didn't want to cause panic by mailing everyone out, hey, you may have arsenic in your water. But we did want to start gently suggesting whenever people called into the health department for water samples that they might consider adding an arsenic test on there. The cost of the arsenic test is roughly $20. That's a pass-through cost. That's exactly what it costs us from the lab. We just charge whatever the lab fees are. We do charge to go out there and take the sample, but otherwise, adding it on to the other tests was a relatively small expense. Next slide. So eventually, and I'll talk about the results here in a second. Eventually, we decided to kind of target specific areas whenever we got a high result from that initial campaign. That resulted in us targeting Centerville Road on the eastmost side where it intersects 42. And we sought to about 12 houses there to take a look at. In that case, we waived our normal, what we call our runner's fee, our charge, our net, the 9 hours to go down there and take the sample, whatever. We said, hey, if we do these all at once, it won't cost as much anyway, and we'll just do a direct pass through on the lab fee. So about $20. The other great thing about this plan was that arsenic doesn't have the same kind of sampling procedure that other samples require. So we could take the test, we could pull the sample literally from a hose bib outside. That made it a lot easier. People didn't have to take off work. We could just drop by the house, grab our sample, and send it off to the lab. All right, next slide. Thank you. The result of that is that we found arsenic in over half the samples that we've taken in Greene County. And today that's about 80 samples so far. 19 of them were above the maximum contaminant level. That's 25%. 25% of the samples that we've taken have been at a level that are likely to cause health problems. 3 of our samples were 10 times over that limit. The highest concentration we had down on Centerville Road was 217 parts per billion. That's extraordinary. We're endeavoring to put together a heat map of where the problem concentrations could be. The issue, though, with arsenic is because it's so highly specific to that, what they call a lens, wherever the well is tapped into directly in that small little area, it's very specific. So what might be a high concentration, a couple hundred yards on each side of one well could be 0 across the street. So it's a little tricky making overall recommendations. It's just a matter of convincing people that it's important to get that test done. As far as treatment options, it is a little difficult to treat for arsenic. There are 2 flavors of arsenic, pentavalent, trivalent. I think I cut that out of this presentation just for brevity's sake. What you have to do at certain levels is actually chlorinate the water and then remove the arsenic, because it converts the valency of those atoms to a kind that will stick to the filtration media. What we're seeing anecdotally is that for levels up to about 100 parts per billion, the standard reverse osmosis filter that folks have at their kitchen sink, with that little side spout and the little lever, that's doing a pretty good job of filtering out. But once you get above 100 parts per million, then you're talking about much more significant treatment issues. Next slide. Oh, I didn't cut this out. I apologize. And again, we chlorinate in order to chemically oxidize the atom so that it will stick. All right, go ahead. There are 4 basic types to do those advanced treatments. We have adsorbative material, RO, which you're familiar with. In certain situations, actual distillation. There are tabletop distillation units that look a lot like a complicated tea maker or coffee maker, where the water's literally boiled out and the concentrate is discharged. On that note, with any of these, reverse osmosis, distillation, ion exchange, that discharged water is just concentrated, whatever was bad, into something really bad. So then what do you do with it, right? It ends up going into the lymph system. So are we creating a problem for ourselves on down the line? It remains to be seen. Next slide. Yeah, we don't have time for this. This was a very interesting study where a scientist in Nevada was using rust to treat arsenic. It was a really neat, novel way of doing water treatment, really low cost. And I believe it was at a Native American reservation where funds were tight to begin with. Next slide. So for us as sanitarians, my environmental health team, the one thing we learned from this was to keep an open mind. When you get an unusual call about something you haven't heard of, it's important to listen carefully, to not make too many assumptions based on experience, but to actually get the data and see what's going on. The other thing is that we can't let new things like PFAS or whatever emerging things that are out there cause us to overlook the basics, the stuff that we studied in school. It can happen here. And the end of the result of that is that there's really no substitute for good data, as we're finding. So since I gave this presentation a year ago, we've added 30 more samples. So we're kind of exponentially growing in our sample size. We're convincing more and more to get to go ahead and get that sample. We'll continue to do that without causing panic, but with an eye to making people aware of a hidden problem. So any questions for me?
So were these all wells?
Yes, ma'am. All wells. Yep. And we're finding on that note, they all tend to be, I spoke of lenses and that sort of thing, very specific aquifers. So the limestone aquifer, or the stuff that's punched down through shale, they're not really getting any arsenic from that. That's why I say it's these Canadian rocks, quite literally. The glacial till is dragging gravel and sand to these pockets that fill with water that make great producing wells, but that come with the downside of having high concentrations of metals in some cases.
So are these people okay? Or were you
So,
the high levels?
yeah, patient zero is doing okay. Matter of fact, they called me the other day and said, "Hey, do you remember me?" And at first, I didn't recognize the situation, and yeah, doing much better. Moved out of that house actually. Tried to convince the subsequent buyer of what was going on. They had no interest in knowing.
So how do they remedy that? Do they have to get a reverse osmosis water system?
That's the best thing. Sam, we recommend a point of use RO system that has an NSF designation. There's lots of stuff Amazon sells that has no quality assurance to it at all. But the expensive one is, about $3,000 for a good one. You can do a whole house RO system so that everything coming through the toilet, the shower, everything is reduced arsenic in it. But that's very expensive. So we don't get a lot of takers on that.
Have you thought about looking at other man-made old sources? Because when I went to school, one of the things in hydrogeology was that old cemeteries have sometimes been associated with arsenic because embalming fluid had arsenic in it. And if they bury you in a box that then degrades, that fluid can seep out and into shallow groundwater. I was just wondering if you might want to look at, see if there's old
I will do
Civil
that.
War or, even a little bit more modern,
Mhm.
because that was a very common chemical to use in embalming.
That's it. It hadn't even occurred to me, but I will see.
think that there was a thesis done around a cemetery in Dayton at one point. So it might be worth looking at.
Okay, absolutely.
Interesting.
Thank you, Scott.
Interesting. Thank you.
Yeah, sure.
Any other questions?
No, but Jane, before we move on, can I just ask Chadwick, any comments about the person who spoke about the fees?
Yeah, I would say I don't agree with his data. Our fees are not higher than all of the surrounding areas. In fact, they are quite competitive. Every year I get a list from the sister agency environmental health directors that show me exactly what their fees are. So as it relates specifically to the issue of fees, the one I proposed, as an example, the most recent permit that Mr. Connor bought, he estimates the job will cost $45,000. I'm proposing a fee that is 1% of that. 1% of the project cost. And even that still only covers 2/3 of the cost to run my program. When it comes to his complaint about timeline, we've had it could be a misunderstanding. The 20 days it sounds right to me. What he didn't explain to you is that oftentimes we get designs that aren't right or that are lacking a lot. So what he may see as the clock starting 20 days ago is not when the clock started. Yeah, I got it 20 days ago, but I got half the information. So I email back to the designer, hey, where's, X, Y, and Z, or why is this for a 3-bedroom and a 5-bedroom house, on and on and on. So when that happens, the clock restarts. The other thing is, he said 30 days. It's true. That's what we've told people in your 11 years. We've always said we give ourselves 30 days to review design. The fact is, it doesn't usually take that long. It does take a couple weeks because of something else he didn't mention, which is the volume of septic work that we do here in Greene County. And it is not particularly comparable to, certainly not to Clinton, not to Fayette, not to Montgomery County. It might be similar to Clark. That would be a fair comparison. Sewage program size, but yeah, I got the data, you know, maybe I could sit and work on putting together some numbers and showing you, you know, exactly how long it takes. Speaking off the cuff isn't wise for me to do that, but yeah, we've always said 30 days and it doesn't usually take that, you know, certainly not because of our responsibility. So
When you compile the data, would you be kind enough to give other counties timeline too, so that we got something to compare with? Because Mr. Connor's concern is that when compared with other counties, we're taking too long a time. So to be fair, we need to look at that data to make sure that we are.
I can do that. You know, I have concerns about, I've worked with other counties. I have concerns about the way that they run their plan review program. There's a lot of rubber stamps out there. We expect a good design when it gets here, a well thought out design. And it's difficult to, it's not necessarily an apples to apples comparison. If I have a county that is shorthanded and has a tendency or a culture to allow just about anything through, it's a little difficult for me to compare my process of making sure that the design is correct when it gets to the installer and that we're all on the same page and then it meets the regulations. That's a little different. And unfortunately, I believe that to be the case with some of our sister agencies, without calling anybody out.
But of course, for every data, there will be a lot of variables when compared.
Sure.
But like every other data, in every system we see, are we outliers? If we are outliers, that means something is not right. Well, I understand the variables and all those things. Then are the process we are following is correct and comparable? And or is it just we're not as good as the other ones are, putting it bluntly. And that's the reason why I'm asking about the data from what count. The more data you have, you will easily see whether we're outliers.
Okay.
I'm not saying that we are. Please
Right,
understand.
I think we could look at some rudimentary data and information from the other counties, and I mean, you can see it. Right up here on the wall, we are all about quality improvement and studying process and, you know, maybe even include some from the other counties to what our process looks like compared to theirs. Should that data warrant that we do something additional, but, you know, as Shadrach said, regardless of all of that, the cost of that site install, that's only 2/3 of the cost of what it takes us to complete that work. And as he's mentioned before in cost methodology, our cost methodology is spent on total number of hours spent in a particular program, the number of systems that we're putting in. And that is going to vary county to county. So it's really not an apples to apples comparison, but certainly we can put that data together to the best of our ability to come up with something. As he said, it's always been 30 days because we know that there can be delays, and sometimes those delays are not what's happening on our end. Sometimes if you're working with a contractor, they are not getting the information in order for us to even decide if it meets the code, you know, your high revised code. But we will put together what we can for the next. You're not.
I'm giving a wrong impression. But in any time when there is a concern, those steps sometimes we follow. Now I'm in medical field, every day we face this data and comparisons and all the time. One of the things is mainly to look at, first of all, the broad spectrum to see whether we are outliers. If we are outliers, outlier doesn't mean that we're doing bad. Just then that gives an opportunity and a reason, a demanding reason to analyze why we are outliers. Because genuinely there is a reason, that's fine. If not, if there is room for improvement, we should, because the public's concern is very important. If we understand than others, we need to address that. So collecting the data first, comparing with other counties is important. Then if we have really outliers, then let's look into it.
We have a really tight group of environmental health directors, so I imagine it'd be pretty easy for me to reach out to them and see what they could tell me.
Yeah, with some of the differences, you could explain like as qualitative to go with the numbers, some of what you just said about there's a difference in the process, there's a difference in expectation, the time count can be viewed different ways. If you count it from the first time we talked versus the first time you got me the final, complete, proper thing to assess, you know.
The other thing I didn't mention is that a 30-day time frame for a plan review for any of my programs is standard from the Ohio Department of Health. I've got 30 days to review food plans. I've got 30 days to review campground plans. Well, 14 days for a different set of campgrounds. But anyway, it's usually 30 days. So that's where that number comes from to begin with. But I will absolutely reach out and see what I can find out.
His measurement for excellence was totally time. He didn't mention anything about the quality, and I don't know if you have, is there a lot of back and forth on these, or do you mark it up and send it to them and then they get you, they make some corrections, or how does that part of it work? And do you have any way to measure what the quality of your, reviews are? Has anybody ever chimed in and said, you guys do great reviews, or this has been very helpful, or how's that work?
So is there, let me take it piece at a time. Is there back and forth? Yes, there's at least back. It's the forth that we have problems with. A good example of that, I had a designer submit 2 or 3 things early in the spring. In late summer, he demands an answer, wondering where we are on this. Well, 4 months ago, we have the email that said, I need this, this, and this. I get copied on that. So the program manager and the environmental health director, I need these things. He just didn't follow through. So, from that perspective, there's not, I can't twist the designer's arm. The other thing I frankly object to is Mr. Connor's not a designer. So I'm not sure I can speak to his numbers. He's an installer. So who's telling him it takes 20 days? I don't know that, because he doesn't draw designs. Other folks do that. He takes their designs and then installs the system. So, I'm not sure I agree with that part either. Is there quality assurance? Yes. Whenever there's a problem, it gets copied on the program manager at least, and then it can go to me if it's significant enough, and we can have a group discussion about what the situation is, especially when it comes to repairs, because they're complicated. Sometimes you need variances, right? And things can get a little weird. That would be the quality assurance, is just that personal review of what my sanitarians are doing and what the design looks like. So.
Thank you.
Any other questions? We'll move on to the financial reports. Noah?
Sure. So we're 3/4 of the way through 2025 already. That's hard to believe. So we are looking at data from September. 75% would be your rudimentary metric for revenue. Roughly going to be there or above. But we know how that can vary based on how our funding sources are. So the general fund, always look there. I want to make sure that's performing well. That's at 110% of what was anticipated, and it's up 7% from last year. So that accounts for basically half of our revenue in that fund. So everything looks good there. Our next largest fund is the Clinical Services Fund, and we look at that, and it's at 88% of what was anticipated. So again, everything looks pretty good there. Overall, we're at already basically what we anticipated in totality for the year to be collected. Obviously, with still a quarter to go. So revenue is looking right where it needs to be. For expenses, we can use that 75% as a little bit better of a metric, since personnel cost is our largest expense and it's a fixed cost. We can use that 75% with a little bit more accuracy. So when we look at the expenses and we look at our largest fund, which is again the health fund, it's at 72% of what was expected to be spent for the year. So it's right on track with that 70%. And then if we look at our clinical services fund, which would be the next largest fund, it's at 68%. So again, right around the 75%. The other ones, as you look down that grayed out column, you can see the majority of them are all at or below that target, with a handful of them being above. The one that you see that's the largest above is actually the fund that holds that WPCLF fund. So that is the grant dollars that come in from the EPA to then go back out with those installs. So that is not typically budgeted for, which is why it looks like it's a much larger expense than it really is. Overall, though, we're at 69% for total expenditures, which is right beneath that 75%. And if we move over to the financial ratios, we did just have the flip over, recently with the federal calendar, even though we're in a shutdown. As we have some of those grants that are federal dollars ending and then starting back up, our timeline to get reimbursed, we've had a heck of a time with a handful of those grants getting payments in timely. So you can see some of those metrics are going to look worse than they are because we have outstanding money waiting to come in for a handful of those. So like specifically 7509 is federal dollars. That's about 3/4 of the way down that fund description column in the health indicators. It accounts for a very small portion of our budget, but it is one that we have quite a bit of outstanding money. But if you were to look at it, you would not say that it was operating very healthy if you were to look at the metrics across. But understand that there and a few other areas, including early intervention, we are waiting for payments that are owed to us to come in. So overall, though, we're at 82%. So it's a very healthy operating ratio. So we're in a good position for where we're at this point. Any questions about the income expenditure report? Next report is your voucher summary. So those are the expenses paid for the month. Handful of minutes to flip through that, and I'll certainly answer any questions about any of the expenses that you see in there.
I have one proposition. This could go on. I don't know whether anybody ever goes through it line by line and really. Yeah, I don't mean to be disrespectful, but mainly you got so much of work and responsibility taking up so much of time to produce it. It's not up to the going to look at it. Is there any way of making it simpler?
Well, it's an ORC requirement that you get it. So it's one of those reports that it has to be here and has to be approved. If I simplified it, you would just remove the detail and you wouldn't be able to ask a question about a specific expense. I would say it would be easier to maybe send it out ahead of time, but sometimes literally board meeting is on the day that the month ends, so you wouldn't be looking at finalized numbers. And I know in the past, I think they've sent out like incomplete voucher summaries with the caveat that it's not a complete report. But I can go back and see if there's a way that I can make it simpler that still fulfills the requirements.
So one of the things we did in a different board was that simplify it, say that if it needs further, if you really want to look at it, it will be provided or on internet or report take something and you get the dropout of the full detail. So it still is available. Only thing is, whether through this practical.
That I can do with some kind of drop down format and put it in Notion. That can be done.
Just try to simplify it.
Yeah. I appreciate it. It's a lot of detail to look at. So I understand where you're coming from. I'll see what I can do.
No, what's the GDR excavating for $17,000?
I can answer that. That was actually a payment to Mr. Connor, who was just here today, through his
Through the W.
Yeah, through the Water Pollution Control Loan Funds. It's a pass-through fund. It comes directly from Ohio EPA. Well, I wish it came directly, but it's back. There's a little bit of bureaucracy in the middle. In the end, he got paid to do a repair for that, what amounts to a grant.
What is Metopio?
So that is the public health platform that does data analysis that we're using for our next community health assessment in chip work. So we're getting ready to do our next community health assessment, as you're aware. And they'll be assisting us in helping the facilitating of the survey and analyzing of the data that we'll use to drive our next community health improvement plan. No, Cheryl, if you want to add anything more to that?
Pretty much it. It will be a digital format this time, and it is significantly cheaper than the company that we used to do the data collection and analysis in the previous run 3 years ago, 2 years ago, 3 years ago.
3 years ago.
Thank you.
Chadwick, was that the repair of that well that wasn't capped appropriately? That was. We discussed probably about 3 or 4 months ago.
No, it's not actually for a well. It was for a sewage repair.
Sewage repair.
Yeah, it's for low to moderate income families. They apply for it and it'll cover up to 100% of the cost of the repair. And to be honest with you, Dave, I don't remember which site it was. We've done, I don't know, we're working on 7 or 8 or 9 of them. So I don't remember which one it was, but I think it was a mound, I think down in Spring Valley Township, but.
Any other questions about the voucher summary? Moving on. We'll go with the salmon color. Yep, an extra one tonight. So the next one is the salmon color piece of paper, and that has your appropriation transfers on it for the month. It also has one advance on it for the month, and I already kind of hinted at this with your income expenditure report. So because the money is stuck right now for 7509, we've had to advance some money from the general fund to ensure that we can pay the bills until we get paid. And then we will send that money back to the general fund. Typically, we don't have to do that here. And the white piece of paper is going to be my way to help ensure that we don't have to do that moving forward. But we'll get to that in a second. So that is something you usually don't see on here. So just specifically wanted to point that out. So that's down at the bottom. It's an advance for $4,000. It's the last entry on your top rows. And if you're curious about the largest one on there, that's for 61,000. That is our movement to Microsoft E5 and upgrading our cybersecurity and all of our IT infrastructure, especially in accordance with all the new requirements that we have to have for cybersecurity. So this will allow us to have a very robust cybersecurity system. We were on E3 before, so we are very accustomed to NIST and its requirements, and we've been working on that for a while. Even before the recommendations came out, we were already in NIST compliance and doing that. So this is continue upgrade to our IT infrastructure. Any questions about the salmon colored sheet? Cool. So again, hinted at another one. So the white sheet is one you guys are familiar with, but we only do it a couple times. So this is a fund-to-fund transfer. It's unique in the sense that we're going to be establishing a new fund with this one. So from time to time, we will have to create new funds, usually for it's a specific project or it serves a special purpose. What we're doing with this fund is creating a new general fund for a specific section of the health department. So we have our general health fund, in which the property tax levy goes in and a lot of our administrative costs come out. We have our environmental health general fund that accounts for all of the programs that are mandated and unfunded and aren't required to have special revenue fund by code. And then we have the community health services fund that has all of Jennifer's programs in it largely. One fund that we don't have though is when we did the realignment with the organization with the Foundational Public Health Services Framework and we created Cheryl's position, she got a realigned team, but we did not establish a fund for her. So her programs are kind of spread out all over the place in different funds or in individual funds. So what we want to do here is establish a new fund for her programs that are in alignment with how we've organized the entire health department and put all of her funds, all of her programs in that fund so they have their own operating fund. And one of the things that it will do is we'll avoid doing advances like this because we will have all of the cash inside that fund and it won't be a cash flow issue because it'll be pooled resources. Because of the way we do accounting, we still won't have commingled funds because we can do cost centers for everything with our program codes. So that's not an issue, but this will allow us to reorganize and make things more efficient with all of her programs in a fund. We will move Jennifer's outlier programs that are in special revenue funds inside of her fund and just reorganize things to try and reduce our fund tree. So there's less funds to look at and there's less money spread out, and it'll allow us to kind of put all of our assets in larger pots, if you will. So that is what we want to do with this. This will also allow us to move some additional money out of the general fund. So we'll use that money to establish her fund is what we're asking for with this white sheet of paper.
What will that be called?
So right now, it doesn't have a name because it gets assigned from the auditor's office. So I gave it the next fund code in line, which would be 7516. And I'll probably tell them just to call it the PPP general fund or planning fund. They're not going to want to do her whole title name for the fund. So I'll probably shorten it to PPP general fund or something like that. But it's whatever code they give me to. So if 7516 has already been taken, they'll assign a fund code to them. But they won't do it without Board of Health approval. So
Okay, so we need to vote on that too.
yeah, all of the items tonight and this one included. Yeah.
Okay. Any other questions?
No, I just, almost. Yes.
Okay, we need a motion and a second to approve the financial reports, which is the monthly income and expenditure report, the voucher summary, and the appropriations transfers, and also the 7516 fund.
Yeah, you can just say the establishment of a new fund. Yeah.
I think that was Dr. Powell's motion. Is that okay?
Motion to.
Okay.
Yeah.
I'll second.
Okay, thank you, Nancy. Any other discussion? Okay, all in favor, say aye. Opposed? Okay, motion passes. Move on then to the governance report. First one, governance committee.
No report.
Performance evaluation committee, which is still hardening. We did not move for that committee. Planning and finance committee.
No report.
And we do have an addition on the amended agenda, which is the nominations committee. And I appreciate the fact that Dave and Angie were part of that committee along with me. And we met on Monday, a conference call, and we have to choose a nominee for the vice president for next year for 2026. And Tim Root have graciously accepted that nomination. So we will be voting on that at the next meeting. Do you have anything you want to add, Dave or Angie?
It was a well-run meeting and I think we've got a good nominee. Thank you.
I agree.
Thank you all for doing it.
Angie, anything? Okay, so, we can skip number 6 since we've already done that. And move on to new business. City of Xenia requests release of delinquent and current taxes owed Greene County Public Health for East Third Street. I won't read that parcel because it's pretty long. Case number 2024 CDU 0572 vacant land. The Health District currently collects 67 cents a year on this. So I need a motion to release this. In a second.
I'll send.
All in favor, say aye.
Aye.
Opposed? Okay. And then, we have an addition of the environmental health technical position, which the position description was included in the packet. So, do you need to, would you like to speak to that?
Yeah, I can real briefly. So it's somewhat popular for many health departments to have a technician position. A technician doesn't have to meet the qualifications that a full-blown registered sanitarian or sanitarian in training would have to meet. The technician can do a lot of administrative work that frees up a sanitarian to do the things that only a sanitarian can do as required by law. So when we created this position description, we consulted with sanitarian board, the lady who runs that, to make sure we described exactly what they can do. We've never had that position here at Greene County, at least not in modern memory, according to leadership, and having it would be could be a really key position when we need to take some things off my team's plate, frankly.
Okay, any questions?
Do we have somebody in mind for this position, or is this a position that you'll be looking to hire down the road?
We likely will have someone that we put into this position. So what happens is sometimes you have a certain amount of years to complete the RS exam. But you have not taken the test or successfully passed it within that time frame. So it just allows us to keep the employee going until they can pass the exam. So it's kind of like your NCLEX for nurses, you know, you get a couple shots at it. So yeah.
Okay, any
Does
other?
this have a salary range on here or?
It does. It has the grade and subgrade in which it would be in. So it's up at the top. Under FLSA status, it's a B23 for us. It doesn't have the monetary range in there, if that's what you're asking, but it's $20-ish an hour would be starting.
And we got money in the budget for that.
Yeah.
Yeah, okay.
Any other questions? Okay, need a motion and a second to have this job of environmental health technician.
So moved.
Thank you. That's Angie. A second. All in favor, say aye. Opposed? Okay.
Thank you all.
Okay, the next is really wonderful news. It's the reaccreditation letter from the Ohio Department of Health from Bruce Vanderhoff, and we have a copy of it right here. Yeah. Very nicely done. And I'll pass it around if y'all would like to read it. The letter, copy of it is also in your packet. Congratulations. Congratulations. It's a wonderful thing. You should be so proud, and we're proud of all the work and everything.
Thank you for supporting us. Yeah. We couldn't do it without your support.
Very much appreciated.
I want to congratulate the team and boards for the accreditation. It's wonderful, it's a lot of hard work.
Okay. Dr. Sherritt, do you have anything about to share?
Well, I guess there's a couple things maybe of interest. We really are now starting to kick off the respiratory vaccine season. So if you haven't seen or heard or been involved in it, flu vaccine is flowing now, and then it's COVID. The newest, latest COVID vaccine is now available, and certainly RSV vaccine. So there's indications for all of those vaccines, and we're seeing a lot of interest in people, inquiring about the various vaccines. So that's kicking off now and going in full speed. Literally just before I left the office, of maybe a little bit of interest is that one of our nurse practitioners informed me that a family came in today that one of the children in the family here in Greene County had been confirmed positive for pertussis. And they brought the family into the office for the rest of the family to be tested. None of them were symptomatic, but nonetheless, they were tested. So that's something of interest. And then something that has been really dominating my time lately is the One Big Beautiful Bill Act. And so the One Big Beautiful Bill Act, probably the most significant thing that you may want to know or need to know is that it has established very significant cuts in Medicaid spending. And it's going to be a challenge for health systems, nursing homes, just healthcare providers in general that provide care for patients with Medicaid. That's going to be a challenge. Part of that act, though, was a rural health transformation plan that was allocating $50 billion over the next 5 years for rural health. And it definitely is a work in progress in terms of a lot of certain unknowns in terms of how to apply and the process to go through. But to make a long story short, each state has the opportunity to apply. And I just read yesterday or saw yesterday, you would think that every state would apply for this. So if you break down $50 billion, if it's divided equally amongst the states, that amounts to $200 million a year for the next 5 years. The CMS has said that they are not going to distribute it equally. They are going to take half the money and distribute it to any state that seeks an application. And so that initial disbursement is not based on merit. It's not based on plan. It's simply, if you submit an application, you will be in line for that first 25 billion, which amounts to 100 million a year for all 50 states. Now, the thing that surprised me yesterday, and I have to validate it today, in order to apply for that, the application is due November 5th, but you had to submit a letter of intent to CMS as of midnight on September 30th. It was reported yesterday that 27 states had submitted a letter of intent, which means just a little over half the states are planning on submitting an application. So that means that initial disbursement is potentially more than $100 million, because instead of being spread over 50 states, it's going to be spread over 27 states. So then the second round is an application that then is based on merit. And so at that point, it's not a no fault disbursement. It is, you have to show CMS that you're more worthy or worthy of what you're asking for compared to other states and other entities within your own state. I know this is all complicated. The bottom line is that it certainly appears that there's going to be significant opportunities for rural health. And so we're working on it, Greene County. We have a rural health program in Greene County. FQHCs can also apply for this, and I'm assuming that the FQHCs are doing so. They should if they're not. So this, it's yet to be determined what this could amount to. And in Jamestown, $100 million is a lot of money. So I don't want to minimize that, but by the same token, it appears it could be even much more than that. There are some that are speculating that Ohio might be in line for up to $400 million a year for rural health. So I've talked to Melissa about this already. I think in our plan that we've submitted a plan. Our rural health program has submitted a plan. And then part of that plan is collaborating with the health department and where it makes sense in rural areas for us to improve access, improve experience, and most certainly improve quality. So there'll be more to come. It's a short timeline. I mean, it's lightning speed for the government, for the government to do something like this. The application is due November 5th. The disbursement or the announcement of awards is before December 31st, and the disbursement is in the first quarter of 2026. So that's very rapid turnaround. So we'll see. As time goes, so I'll certainly give you updates.
Can I ask, is it new business, right? So can I ask a completely, that's a very comprehensive one. I was reading about it.
Do what now?
I was reading about it and
Oh, yes.
that's a very comprehensive. Thank you. One of the questions I have is that I don't have any affiliation, but what is the stance of our health department when it comes to vaccinations? Are we following CDC's recommendations, or are we following so-called professional organizations' recommendations, which seems to be controversial? And of course, people will be dependent on your advice.
So we included in the monthly activity report on, I think it is on page 5. So we kind of make the data-driven decision. So under the epidemiology section, it's going to tell you that obviously we've entered virus season and that we're seeing more coughs going on right now inside the emergency rooms. And that the American Academy of Pediatrics is, of course, recommending COVID, RSV, and flu shots for children. I think what's important is that we continue to support the recommendations. The health plans are supporting the recommendations. The AMA is supporting the recommendations. I have submitted the question to the Ohio Department of Health twice now. And I think you just have to understand that there are there's a medical way to answer this, and there's a political way to answer this. But as a public health person, I'm going to tell you what we see because of the disease. We know that this is flu, cold, RSV season. The recommendations have always been this. We still have groups still recommending this. The safest thing that we can do is stick with those recommendations, because we're just at a critical time where I believe that without the schedule and the schedule changing based on data and not ideology, that we place our population at risk of death, or serious illness, hospitalization. And so that is what we've done based on the data and what our epidemiologists is seeing in data right now.
I could not agree more, and especially when you have all these things, especially some pertussis. We all know pertussis and measles becoming a bigger problem. Only reason why I asked that one is, as a government organization, whether we are legally bound to promote what CDC and government says, or do we follow? Because don't forget, the professional organizations have no legal or authority or anything, just because they're good recommendations. What is our stance when it comes to it? If somebody challenges you say that,
Correct.
why are you recommending this when the government is saying,
So Ohio law, it is in one of the current bills that is being proposed to try and keep some Medicaid, Medicare in place. The bill says Ohio following the ACIP, so if that is the law, it would take a change in the law to move away from the ACIP guidelines.
You know, on that line, I wondered, is there any value of having the Board of Health issue a policy statement on recommendations for immunizations in our county? I mean, is that something?
Again, there's probably a medical reason to that, and then there's going to be a political reason or a political answer to that. So, I'm still pressing all of Ohio to come up with whatever the Ohio statement is going to be, and if we need to do additional work beyond that, we will do that.
Okay.
Yeah, as he mentioned, this family of children who have pertussis, it's an unvaccinated family. So now you have a 4-week-old who cannot be vaccinated, who has pertussis. That can be a deadly situation right here within our borders. And I don't think that I want to be the one to say, oh, well, you know, when I know that there's a vaccine available that can help, you know. But we still have to recognize that there is a big push in some communities that want to have these choices. They want us, we've talked about this a lot within the health department, they want to live with a level of risk that's okay, or test the limits to see what this level of risk is. And I can tell you that, while I believe our health department is ready to go, as we were in the pandemic, as we were in H1N1. If you get multiple outbreaks with pertussis, with measles, with tuberculosis, whatever it's going to be, it will tax this health department and the state of Ohio to bring that outbreak back under control very quickly. So we can do it one way, you know, by promoting preventive vaccine, or you're going to see a lot of treatment and a lot of energy put into outbreak control.
And that's just senseless. You know, and when you can prevent it. In my opinion.
Other questions? Okay. Melissa, do you have anything you'd like to?
Well, I was going to point out about the very data that we talked about. Nancy, we did include in the monthly activity report on page 11 more specifics on that question that you had for me. And I did want you to know that around the 20th of September, I had the privilege of going to Delaware. I'm sorry, I couldn't remember where I was. Delaware, to speak to members of all boards of health across Ohio and share a lot about what I share with our internal team, as well as my board of health with our written monthly report, the MAHA report and what is expected out of that. Thanking all boards of health for the support that we get across Ohio in the public health system. So I think Nancy was on that call.
Mm-hmm.
I don't know, Todd,
And that was sponsored by the Ohio Association of Boards of Health.
Yeah.
So we thank you, Melissa, for being there. It was an excellent talk, very much like the report we get on a regular basis that a lot of health departments do not get that information. So we're very fortunate.
Anything else anybody has to share or would like to talk about?
No, I know that several of you are off to the NALBO annual conference. I think Jane and Connie and Todd. And unfortunately, I cannot attend this year because I have some mobility issues that I can't travel. So I'm very bummed by that, but hopefully you guys will come back and give us a good rendering of what happened, and they get to go to Savannah, which is always nice.
no hurricanes. Right?
Yeah, I'm looking forward to it and bringing back what I have to share. I'm sure they are too. You all have anything you'd like to add? If
I
not,
don't at this
then-
time. I did want to chime in on the household wastewater one, but I'm pretty sure our director of environmental health took care of that one. I would ask the group to understand what the process is of that, maybe to look into it or ask him about it. I was very familiar with it from my previous jobs, but it's a lot more than what the installer was suggesting.
Thank you, Todd.
Yes.
I appreciate that a lot, actually. Thank you.
Okay. Well, if there's no other questions, we'll adjourn our meeting. Thank you. Thank you. See you in November.
Yeah.